Well, a warm welcome to today's talk. It's Sunday the 9th of January. Now, we want to look at sequelae today, that which can come after. So you can get COVID-19, or any disease for that matter, have an acute episode, and then there can be complications that can occur days, weeks, months, years, potentially decades after. That's what we want to look at, and we'll be using the example of diabetes in young people in the United States. But before we do that, let's just look at a couple of things I forgot to show you the last time we were here. It's this comparison of new onset COVID cold-like illness and new onset of COVID-19 with respiratory symptoms. In other words, this blue line here is COVID with respiratory symptoms, and this orange line is COVID-like illness. So basically what this is saying is people in the United Kingdom who have common cold type symptoms are more likely to have COVID than they have the common cold. So the incidence of COVID has gone up dramatically. The incidence of colds has gone down quite a bit. So if you've got a cold in the UK at the moment, there's a slightly better than 50% chance that in actual fact that is COVID as opposed to a common cold. And basically, loads of people I know now are becoming positive. I'm sure you know lots as well. Now, I'm not yet. I've tested again today, and I'm still put that on a better camera. I'm still showing negative. So I did have sort of tiredness and a bit of a cold over the weekend. But where are we? But I'm still negative. There you go. So whether the 3 doses of the vaccine are protecting me, I suspect they probably are, because everyone's been exposed by now. We know that. We're all going to be exposed. So that was the first graph, common cold symptoms, COVID cold. It's not saying some people don't get severe disease. I don't want this to be misinterpreted. Some people do, but it's the vast minority. So COVID now the most common cause of colds in the UK. Huge growth in cases. Now, this is the full list of symptoms from the COVID Symptom Tracker app of what people get. So 73% of people who test positive get a runny nose, 68% get a headache, 64% get fatigue, 60% get sneezing, sore throat, persistent cough, hoarse voice, a range of other symptoms, chills, fever, dizziness, brain clouding, sort of brain fog. Some still get altered sense of smell, just 23%. Eye soreness, unusual muscle pains. Interesting, this one was much higher in South Africa, wasn't it? A lot more people in South Africa getting unusual muscle pains, less in the UK. Not feeling hungry, skipping meals, loss of smell, chest pain, swollen glands, feeling down psychologically, which is depression. So that's the full list in the UK, which I thought was pretty interesting. Now, first thing to do is I want to go and look at the Office for National Statistics from the UK, which is here. We look at this quite often. We've looked at this graph recently when we do our numbers updates, but the Office for National Statistics is definitely the best source for information in the UK. So talking about long COVID, so we're talking about sequelae in general, but starting off with long COVID. Long COVID continues to affect more than 1 million people. In fact, 1.3 million people in the UK suffering from long COVID at the moment. That's 2% of the entire population. And that is in the 4 weeks to December the 6th, up to when this data is available. So that is a lot of people. And I think in the States, I'd be surprised if it wasn't 2% of the whole population as well. I would expect this data to be reasonably transferable wherever you are. Long COVID for less than 12 weeks was 21% of the 1.3 million. Long COVID for more than 12 weeks was 70% of the 1.3 million. And 40%, well over 500,000, had long COVID features for more than a year. And if these features are persisting for more than a year, that does become concerning, because you get more worried about the possibility of there being some actual damage to the tissues of the body. Still a lot to learn about this disease, of course. 20% of the 1.3 million reported their ability to undertake day-to-day activities have been limited a lot. Symptoms: fatigue, loss of smell, shortness of breath, difficulty in concentrating are the main things that people are reporting with long COVID. Self-reporting of long COVID was greatest in 35 to 69-year-old age, so less in under 35s, less in over 69s. Interesting. More common in females, People living in more deprived areas reported more long COVID. Those working in health and care and social care reported more long COVID. Those with another activity limiting health condition, in other words, those with comorbidities, that one's to be expected. And surprisingly, those in teaching or education as well. So the only thing that comes to mind there is those in teaching or education or those in healthcare are probably exposed to a lot more people. So in healthcare, on hospital ward, you can be exposed to 100 people a day quite easily, coming and going, and patients. And again, students, pupils in schools, hundreds of them. So teachers could well be more exposed to a different variety of viruses than the rest of us. Now, before we go on to diabetes, I want to look at something really interesting, and this is worth sticking with. It's called Encephalitis lethargicus. So let's look at Encephalitis lethargicus. Encephalitis means inflammation of the brain. Itis, enceph, inside the skull. It means inflammation of the brain. Lethargica means the patients are lethargic, inactive. Now, this is what came after the 1918-19 pandemic. So what we have here is this is the death rate up here from Encephalitis lethargica. That's the death rate, and that's the death. They're the deaths in Scotland. So they're in England. They're in England. They're the figures for Scotland. In other words, it's common figures. The solid line is England and Wales, and as we see, the other countries had similar amounts. So there we are, 1918, 1919. This was the time of the acute pandemic, when people actually had the virus. So the virus began in about 1918 and finished, well, it started to go down quite dramatically in 1919. There were still small amounts of it around actually for quite some time, but it wasn't causing much illness right up until about, right up towards the end of this graph actually, up until the 1950s. There was very small amounts, but basically we could say 1918, 1919. So if we say the pandemic more or less finished about then we see death rates continued to go up. Then they went down, then death rates shot up, and they started going up, 1923, 1924. So this is 3-4 years after the end of the pandemic that this became a big problem. So there was this delayed effect. Now, I'm not saying this is going to happen with COVID-19, not at all. But we do have a lot to learn from history, and we'll see why we have that in a minute. So, and then deaths continued right up until the end of this data sequence in 1940, 1939 anyway. So that was one of the sequelae, we assume, of the 1918-1919 influenza pandemic. Now, that was influenza, it wasn't coronavirus. I'm not saying these are comparable, but it does show that complications can go on for a long time after a mass of people. And of course, right now, everyone is being infected with COVID-19. So I'm not saying this is going to happen, not by any means. I don't think it will. But it's interesting, and it's something we have to be aware of, because the purpose of this channel is not to raise alarm, but there again, it's not to hide our heads in the sand either. It's to be as realistic as possible, and this is the way my thinking's been going lately, and this is a concern. So what's going to happen after that? Now, just a little bit more about this Encephalitis lethargica. Now, I've never seen a case. There are similar disease. There is a similar neurological disease today, but very rare. But when I was training, the old people at the time had treated many patients with this condition. It used to be quite well known. And another one that went after it, called post-encephalitic Parkinsonism, where the people get tremors and rigidity. So sometimes called sleepy sickness, not sleeping sickness. That's trypanosomiasis. That's a tropical parasite. This is called sleepy sickness. So brain disease is an encephalitis. Status-like condition, speechless and motionless. So status means that they're just here but not here really, speechless, motionless. 1 million victims or more, 500,000 deaths. This was a huge sequelae of the 1918-1919 pandemic that not a lot of people know about these days. In fact, I've even done a quiz on some doctor friends recently, asking them to tell me about Encephalitis lethargica, and let's just say most of them struggled. Most survivors never returned to full vigour. Oliver Sacks, famous British-trained American working neurologist, he did a special study on this. Oliver Sacks probably qualified about probably like late 50s, early 60s. So there were still a few around. He did a study on them, and then he did some historical work as well. He said they would be conscious and aware, yet not fully awake. They would sit motionless and speechless all day in their chairs, totally lacking energy, impetus, initiative, motive, appetite, affect, or desire. No mood at all. No desire at all. They registered what went on about them without active attention and with profound indifference. They neither conveyed nor felt the feeling of life. They were as insubstantial as ghosts and as passive as zombies. It's a pretty frightening description from Oliver Sacks, the famous neurologist. And then what he did was, this is really quite fascinating, he looked back to see if there was any historical precedent for this condition, because before about 1915, 1916, there were no cases of this. It just occurred, and then the pandemic seemed to greatly exacerbate it. And of course, we've got a pandemic of diabetes now, which could be exacerbated, which is kind of the point I'm getting to, really. So it seemed to be similar to a disease called the English sweats, which occurred in 1529. Was this after a outbreak of a virus several years later? I don't think we know that. Could have been. Similar condition in Italy in 1597. Similar condition in Germany in 1672. Similar condition in Sweden in 1754 to 57. So he looked back in history and found similar conditions. And as we said, post-encephalitic Parkinsonism used to be very common as well. So that's just a historical sort of reminder, really. An existing condition that just seemed to be massively exacerbated by the pandemic. So what I am concerned about, as I've said, is diabetes, because, well, I'm concerned about diabetes anyway, because at the moment about 9% of the world's population is diabetic. We have a pandemic of diabetes. Diabetes means your blood sugar levels rise. You can't control the glucose in your body. That causes all sorts of complications like strokes, heart attacks, blindness, kidney failure, feet going black, needing amputations, lots of horrible complications from diabetes, as well as the acute complication of death in type 1 diabetes. That can also occur if it's not managed. So risk of post-COVID diabetes. Now, this is from the Centers for Disease Control. This is the paper here in the States. Now, it amazes me that the Centre for Disease Control can take such good data and make it so hard to understand. The writing is really, I think it's terrible. It's so difficult to decode what the heck they're talking about. But anyway, I think I have. So let's just look at it briefly. And basically, there is an increased risk, of course. Now, European paediatric, American spelling, paediatric populations during the COVID-19 pandemic had showed increased risk of COVID-19 leading to more diabetes. Now, we know that increased risk of severe COVID in people with diabetes already, but European data is showing in all age groups, as far as we know. We don't have specific figures on it, but people who have COVID are more likely to type 1 and type 2 diabetes. Type 1 is the insulin-dependent type, where it's an autoimmune disease that destroys the insulin-secreting cells in the pancreatic islets of Langerhans, the beta cells in the pancreatic islets. Type 2 is more an inability to use insulin, usually, although type 2 is a bit of a complicated disease. If you want to know about diabetes, I have done a full video series of 23 lectures on diabetes, and I'll put the link to the first one if you are interested in following diabetes up seriously. Increasing the number of type 1 diabetes diagnoses, unfortunately. Increased frequency of severity of diabetic ketoacidosis. Now, if someone develops type 1 diabetes and they're not diagnosed, they'll develop what we call diabetic ketoacidosis. So this means the blood becomes acidic and there are ketones. The ketones accumulate in the body, just the same way as they do to a lesser extent with a ketogenic diet, which you've probably heard of. So Centre for Disease Control, they took groups. Diabetes incidence among patients aged less than 18 after a COVID diagnosis makes sense. Diabetes incidence amongst those matched by age and sex who had no COVID diagnosis. So good that they had one group there and one group there to compare the two groups. Diabetes in people who hadn't had COVID, diabetes in people who had COVID. And obviously both of these groups developed diabetes, which you would expect. But they also did a third group receiving a group who received a pre-pandemic non-COVID-19 acute respiratory infection diagnosis. So basically, they were looking at people who had COVID, people who hadn't had COVID, people that got diabetes who hadn't had COVID, and people who got diabetes who had COVID. So people who developed diabetes who had and hadn't had COVID. I told you it was difficult to understand. It really is quite, they seem to have a knack for putting this difficultly, unless it's just me not reading it clearly, but there you go. Anyway, results. First group, there was 80,000 patients, 81,000 patients in the first group with COVID-19 diagnosis. New diabetic diagnosis was 0.08% of those, that's 64 individuals. New diabetes diagnosis was therefore, they say, 31% more likely to occur. Now, I know you can't work that out directly, but we can assume that the statisticians are correct. I don't question that. So new diabetes diagnosis, 31% more likely to occur in that group. That's patients under the age of 18 who had COVID versus patients who had not had COVID. So this would indicate a 31% increased risk in under 18s of diabetes as a result of a COVID-19 diagnosis compared to those not diagnosed with COVID-19. But then they had another study, another cohort group, and this was a much bigger group, 439,000. The reason for this is it's different insurance categories in the States and different insurance providers, so it does get a bit confusing. But here, new diabetes diagnosis was 0.25, much, much higher, 1,233 patients. Now, the difference is that people in this group probably presented with more severe disease, and there was probably more adults in this group, so they hadn't completely differentiated between those under and over 18. But anyway, what we see there is 166% increased chance. So what we can say from this data is that there is, both studies show there is an increased risk of diabetes after COVID-19 in under 18s. And we can say that risk is between 31% increased risk and 166% increased risk, which of course is pretty pathetic error bars. It's rather big, but we can say there is some increased risk. Is it 31%? Is it 166%? We don't know. But they're the figures we currently have. So we can say there is an increased risk. New diabetes diagnosis in under 18s. Non-SARS coronavirus 2 respiratory infection was not associated with diabetes. Now this is interesting. So people who'd had respiratory infections, viral respiratory infections, were not prone to get an increased, where they were not more likely to get diabetes unless that respiratory infection was COVID. And I have wondered this for a while. Can random respiratory infections lead to type 1 diabetes mellitus particularly? And the answer from this data is no. Non-COVID respiratory viruses did not increase the risk of diabetes. So that's pretty interesting in its own right. Now, they did think that more severe COVID would increase the risk of diabetes mellitus, but they weren't sure about that. So we can say there's an increased risk. And this was taking patients diagnosed with diabetes at least 30 days after their COVID-19, at least 30 days after. So that's 30 days, 40 days, 50 days, 60 days, 70 days and upwards. Is there going to be more diabetes diagnosed over the next few years, though? Is this coming slowly, or is that the risk over now? Well, this is what we simply don't know. We simply don't know that. Just the same as in 1920, they didn't know what the risk of Encephalitis lethargicus was after the Spanish influenza, as we call it in the UK. The Great Flu Pandemic of 1918-1919. Anyway, implications of this. Importance of COVID-19 prevention strategies in 18s and unders, the CDC say, particularly with reference to vaccination, according to the CDC. Monitoring for long-term consequences, so we need to keep monitoring for type 1 and type 2 diabetes. As I say, this was 30 days, at least 30 days after, but what about 130 days? What about 330 days? What about 3 years? What about 5 years? We simply don't know. And we need to do lots of screening. And I think this is fair for adults and children. So if you have had COVID-19, why not screen for diabetes? It's a very simple blood test. It would make perfect sense to do that. I'll have lots of GP shouting at me saying we don't want thousands of patients coming for needless tests, but you can get very simple glucose tests. And I'm also going to give you a few clinical features now. Now, they do vary quite a bit depending on whether it's type 1 or type 2 diabetes. For type 1 diabetes, the classic triad is weeing a lot, polyuria, thirst and weight loss. They're the three classics. Now, this is the CDC also saying increased hunger. I must say, in my experience, I found the opposite. I found patients more likely to be anorexic and not hungry, but that's what the CDC are saying. They're saying increased hunger. If so, I would say in the early stages. Fatigue, stomach pains, nausea, vomiting, certainly well known. Now, also, I would like to add to the CDC's list from Diabetes UK, genital itch or thrush. So thrush is like the fungal infection in the mouth or vagina, or indeed the glans penis can be affected. Cuts and wounds that take longer to heal. I'd also add to that spots and boils, more infected spots and boils, because in diabetes, when the blood sugar is high, it's harder to combat tissue infections. So infected spots and boils are more common. Blurry eyesight will develop over a little bit of time, because what actually happens is the sugar gets into the fluids, the humours, the vitreous humour and the aqueous humour in the eye, and alters the refractive index of the eye. If it's getting worse, if someone's developing diabetic ketoacidosis, then the breath smells fruity, like pear drops, nail varnish remover. It's an acetone smell. It's a very characteristic smell. And of course, as we said, you get the same in people that haven't been eating carbohydrates. So you get the same smell in people that are starving, if someone hasn't eaten for a couple of weeks, or even less than that, even for a few days. After about 3 or 4 days, you start getting this smell. Or also people that are on a deliberate ketogenic diet where they don't eat carbohydrates. Later on, you can get deep or fast breathing called Kushmal respirations. It's called air hunger. The patient's like it's as if they're gasping for air. Skin tends to be dry, blood pressure goes down, they'll become confused, feeling tired or sleepy, and eventually coma. So things to look out for. And of course, I'll post all these, and these are already available on websites. Now, what's causing the post-COVID the post-COVID diabetes mellitus? Well, they put forward a few ideas. Direct attack on the pancreatic cells expressing angiotensin converting enzyme 2 receptors. In other words, the virus directly affects the beta insulin producing cells in the pancreas. That is feasible. I'm not sure it's true, though. I'll come back to that in a minute. Stress hyperglycemia resulting from the cytokine storm. Well, yes, possibility. Alterations in glucose metabolism caused by infection. Well, again, possibility. But precipitation of pre-diabetes leading to diabetes, much more likely, I would have thought. The reason I'm not that keen on this one is I don't think that this would actually lead to a type 2 diabetes. So if there was direct viral damage of the beta cells in the pancreatic islets, leading to a reduction in insulin production, that would actually be type 2 diabetes, because by definition now, by the latest definitions, type 1 diabetes is an autoimmune disease. It's an autoimmune diabetes. So destruction of the beta cells by autoimmune mechanisms would be type 1 diabetes. So there it's an immunological mechanism that destroys the beta cells. If it was direct attack by viruses or bacteria or pancreatitis or alcohol or whatever it is, directly into the beta cells, that would technically be a type 2 diabetes. And interesting that the CDC don't seem to quite get that one. They do not mention the autoimmune reaction which would actually cause type 1 diabetes. So pretty surprising that the writers of this article don't really seem to grasp the autoimmune nature of type 1 diabetes, which I must say did surprise me. They didn't quite seem to know that type 1 diabetes, I'm sure they do know, they just forgot to write it down, but it's a bit strange, but there you go. So I hope that's not unduly pessimistic. It's not that I suspect these things are coming. If we could do something about the pandemic of diabetes anyway, that would be one really good idea. But can there be more long COVID? more chronic fatigue, more of these problems that people are describing. Well, we know there's already 500,000 in the UK. Scaling that up to the United States, that will give us about 2 or 3 million people suffering from this in the United States at the moment. Will more develop over time? We simply don't know. Is the historical precedent for this developing over time after pandemics? Unfortunately, there are historical precedents for sequelae developing after historical pandemics. So this one's going to run for a while. We will follow it with interest, and thank you for watching this talk.